and I've got the recording started.
Well, good afternoon, everyone, and thank you for joining us. At any time, if you cannot hear me, please let me know through the chat or send a chat to Allie, and she can text me if I don't see it on the chat on Zoom. So good afternoon, everyone, for joining. Today, our goal is really to discuss a little bit about value-based care, MACRA. I've titled it the 2019 update. Really, it's a discussion over about a MedPAC report that just came out. So let's go ahead and dive right in. So I always like to start all my value-based care presentations with this graphic showing kind of the foundation of thought that we have here at the Indiana Rural Health Association. Regardless of political preference or political parties in control at the federal or state level, at the bedrock of everything that we're doing at IRHA and within the industry, there's a practice transformation currently occurring from volume to value. And there's a lot of different programs around that. MACRA is one of those programs, but ultimately our goal within our program here is how do we get a healthier population and how do we get a more profitable healthcare provider. I always like to start with a little disclaimer that no one loves the messenger who brings bad news. I am not here to say good or bad about this program. I'm here simply to convey the facts and the way that I interpret all the reports that have been coming out of the government recently, and giving some areas that may need to be further considered at your practice. So let's go ahead and dive in. First few minutes, if you've heard me speak on MACRA, are going to look like review slides. I apologize for that. But I really want to make sure everyone is up to speed on MACRA and the law, some of the different programs that we have, and then really the majority of today's presentation will be talking about this new MedPAC report that came out back in March. So MACRA 2015, it's the Medicare Access and Chip Reauthorization Act. It was really founded as a portion of the CMS Innovation Center, or CMMI, that was started under the Affordable Care Act, Section 3021, which really focuses on how do we test new payment and service delivery models, how do we figure out if those new models are working well, and how do we engage our stakeholders to develop additional models for both Medicare, Medicaid, and CHIP, or the Children's Health Insurance Plan. And if we look through the ACA and some of the laws that passed, high-tech, and then MACRA, they're all interwoven together under the President Obama's administration for system transformation. And they set the goal under President Obama's administration, really by the end of 2016, so a year and a half ago, that all Medicare payments, 30% would be from an alternative payment model, so a capitation, an ACO, a global budget of some kind. 85% of all payments, including that 30%, would have some sort of fee for service linked to quality, and then 15% would not. The goal then, over the next 2 years and end of this year's, half of all payments, an increase of 20%, would go to alternative payment models, and 90% would go to a link to quality on the system. So what are the goals of MACRA? Well, really it was threefold goals. First off was ending the sustainable growth rate, or SGR formula, for determining Medicare's payment for healthcare provider services, making a new framework for rewarding healthcare providers for giving better care, not just more care, and combining the existing quality reporting programs into new systems. To give you an idea, the SGR system was put into effect in law in 1999, so under President Clinton's administration, with the goal of capping the growth of Medicare expenditures linked to a lot of different things, including GDP, expenditure, and overall enrollment. That program only capped for 1 year and then was waived every other year since then. And to adjust for that, if they were to implement the cap, it would have been a 21% reduction in Medicare reimbursement in 2015. So either they need to redesign that program, repeal and redesign that program, or put in that 21% penalty, which we knew would be detrimental to several of our facilities. Hence, here comes MACRA. MACRA was introduced, again, this is review, but it's important here to highlight that MACRA was passed as a bipartisan piece of legislation. It passed the House with a vote of 392 to 37. It passed the Senate with a vote of 92 to 8. And President Obama signed within 2 days, of receiving this piece of legislation. Also notice that President Obama signed it within 2 days of receiving it, and the Senate passed it within about 3 weeks of receiving the legislation. So with all the healthcare debate that's occurring under President Obama's administration, as well as all the debate that's occurred under President Trump's administration, this piece of legislation had support from both sides of the aisles and both extremes of both sides of the aisles. Now that we're in year 2 of the Quality Payment Program at MACRA, year 2 was the first year under the Trump administration and his leadership, primarily Secretary Price and now Secretary Azar, as well as Administrator Burma of CMS, and they said, well, you know, we kind of have our own goals of MACRA legislation, how we view it, yet very similar to the goals of the initial legislation. One was to improve health outcomes, one was to spend wisely, one was to minimize burden of participation, and we'll get into a little bit why, and then we want to be fair and transparent with our legislation. So for those of you who are new to MACRA, very quick, and there's recordings on our channel to watch for more detail, or my contact will be at the end. Be more than happy to discuss. But MACRA created the Quality Payment Program, or QPP. It only affects Medicare Part B reimbursement, so this does not affect A, C, or D. And really developed 2 unique programs. It developed the Merit Incentive Payment System, or MIPS, and really emphasized the advanced alternative payment models, or AAPM. Providers have a choice. Do they want to go into MIPS? Do they want to go into an AAPM model? If not, they're defaultly added into MIPS unless they meet an exclusion criteria. Again, for today's presentation, that would take too much time, but several providers are excluded for various reasons, either low volume, rural, or new to the Medicare program. Rural facilities were also directly affected by this. The critical access hospital billing mechanisms were not carved out and still are not carved out in year 2 of the program for both Method 1 and Method 2 billing underneath that CA designation. So critical access hospitals are involved in all that legislation. Here's the initial historical timeline, and I'm now saying historical timeline because some laws have changed this already. The Bipartisan Budget Act of 2018 that passed has changed this. We're still not sure how, but has changed this. But basically, this program was introduced in 2015. 2016 was our planning year. We had our first round of performance measures in 2017, and then by 2019 or January of next year, in a short 7 months, our payment adjustments will be beginning of 4%, positive and negative, and those will increase to 9%. We'll get to that in a minute. So for the MIPS program, how are we currently scoring it? Last year, 2017, we looked at 3 categories of score. Quality, which made up 60% of the overall score. Advancing Care Information, which is the old Meaningful Use program, or EHR incentive program, counted for a quarter of the program, or 25%. And then clinical practice improvements. So are you doing activities that are going to prove and show that you're improving your practice? And that accumulated 15%. This current year, I'm going to flip, is looking at quality at 50%. Cost is getting added into this for the first time at 10%. Some information on your 2017 costs are being shared with you, but did not affect your overall scoring. And advancing care information was a quarter of your score, and then improvement activities was 15% the same. As of right now, a big asterisk there, as of right now, we believe that in 2019, quality and cost will become an equal split to 30% of each, 30% quality and 30% cost, and then advancing care information improvement activities will stay at 25 and 15. Proposed rule and final rule have not come out, either one, so we're going off of what was said in 2018, which could be changed by the MedPAC report that we'll be discussing in a minute. So what is the timeline for reporting? So hopefully everyone is well aware of this. So 2017 was a calendar year reporting year. All reporting was due at the end of Q1 of 2018. This will be the same cycle every year. So Q1 of each year will be the reporting on the previous year. Feedback will become available at some point Q2 through Q4 2018. And then in 2019, that payment adjustment will begin January 1st. So we'll be a year of measuring and gathering, a year reporting and analysis, and then your payment adjustment that following year. So it'll be a 3-year process for any year that we report on. So first year was 2017, like I said. That was going to lead into a 2019 payment adjustment of positive or negative 4%. 2018 would lead into 2020 of 5%. 2019 would lead to 2021, and then 2020 into 2022. Notice my red disclaimer at the top of the slide. Before Bipartisan Budget Act of 2018, these payment adjustments, both positive and negative, were set by statute. These were set by law. CMS did not have the legal authority to change the adjustments. They had to stay as big as these were. In the Bipartisan Budget Act of 2018 that passed this last March, that's changed and removed that part of statute and giving more discretion to the Center for Medicare and Medicaid Services to set these adjustments better. They're still not coming out yet with what that means or how that will be implemented, but it's important to highlight here that there is now no longer that statutory requirement for these thresholds. They may keep them, and that is within their legislative authority or their executive authority of implementing that legislative law, but very well they could also repeal them. The other part of MACRA was the Advanced Alternative Payment Models with A-APM or double APM, which is critical to understand what these are in preparation for our MedPAC discussion in a minute. So what is an advanced alternative payment model? Well, these require physicians to bear some sort of financial risk. So they're not just a positive financial gain, there's also a downside financial risk. They're going to have some sort of quality associated with them, comparable and comparable to MIPS, and they're still going to be required to use that qualifying EHR. So they could not transition back onto a paper record, for example. What are some of the programs that we're seeing right now? Well, there's CPC Plus, there's end-stage renal disease care. We're seeing a lot more bundled payment models appearing, especially around knee and hip and ortho type procedures. We're seeing different kinds of ACOs, the next-gen ACO, Track 2, Track 3 Medicare Shared Savings. There's also the Track 1 Plus program that came out, and the oncology care model. Only one new model within the AAPM model has come out under the current administration, President Trump's administration, and that was a bundled payment model looking at all of these different disease pathways. Notice majority of them were inpatient, only 3 were identified as outpatient care, so really trying to focus on an inpatient acute care visit and subsequent follow-up, or for cases of major surgery, some pre and post follow-up. So I'll just leave this slide up here for a minute. These are the areas that the current administration is focusing on. We also are hearing discussions and public comments and speeches given by various different officials within CMS and within Health and Human Services that there will be several new models coming in 2019 and late 2018, but we're not sure quite yet. One model was released last week, open for comment, and I didn't have time to include that in today's presentation, so there's a lot of updates coming. So I promised I would keep that brief, about 15 minutes of overview. I really want to get into some of the new remarks that have been made by current leadership of the Health and Human Services Administration, as well as what this MedPAC report shows. So first, if we look at our confirmation hearings that were done back in January, February, and March of 2017, when the Trump administration was appointing their new executive, if we look at Tom Price, he was at the time going for Secretary of Health and Human Services. He has since been replaced by Secretary Azar. But Secretary Price made the comment, you cannot just change Obamacare overnight. What we believe is important is to allow individuals voluntarily to move to the kind of health coverage that they seek for themselves and for their families. We're not going to force anybody to do anything like the Obama administration has done. And I really want to draw your attention in this quote to the word voluntarily. And you're going to see why in a second with MedPAC. But really a discussion of, we can't do this overnight, but we want to create some sort of voluntary transition. Secretary Verma, in her remarks, first said that CMS is a $1 trillion agency and covers over 100 million people, many of whom are among our nation's most vulnerable citizens. providing high-quality, accessible health care for these Americans isn't just a luxury, it's a necessity and often a matter of life and death. So again, I wanted to show you this quote here from Administrator Verma, that we want to have a high-quality, accessible healthcare system, and that it's needed, it's a necessity. Quickly after that remark, though, she followed up with this remark: I applaud Congress' effort to pass MACRA. I think it's an important step forward, not only to providing more stability for providers, but also moving us towards better health outcomes. So again, this is in the first about 8 minutes for testimony. She applauded the steps of MACRA, again, a bipartisan piece of legislation, and the goal of having better outcomes. And then yesterday, not even about 24 hours ago, Secretary Azar, in his first public appearance in the last 3 weeks, since being hospitalized twice for diverticulitis, at the World Health Care Congress, made the remarks, beyond the market power HHS has through our health programs, the federal government has other important roles to play in healthcare innovation. One, as a steward of the largest collection of healthcare data on the planet, and two, as the world's largest funder of biomedical research. These remarks are on a value-based care system, so not MACRA specific, but really want to highlight as current of a quote as possible to show what was being done. If we look back at Health Data Palooza, which was a conference held in DC Thursday and Friday of last week, maybe even Wednesday of last week, a lot of discussion of data sharing, patient data with patients, and using data to drive our healthcare system to make important changes and modifications. So, all that to take us to the highlight of today's presentation, our MedPAC recommendations. My goal here is about 20 minutes to review their recommendations, which will leave 20 minutes for discussion at the end, and discussion amongst everyone who's on today's call. So what is MedPAC? If you're not familiar with MedPAC or not thought about them in a while, so MedPAC is an acronym. Like anything in healthcare, we have to have an acronym. And it stands for the Medicare Payment Advisory Commission. And this was established back in 1997 by the Balanced Budget Act. And their goal is to advise the U.S. Congress on analyzing access to care, quality of care, and other issues affecting Medicare. I want to highlight this. This is a legislative branch committee. So this is not affiliated with the HHS directly. This is something appointed by Congress, both the House and the Senate. All reports were shared with the Speaker of the House, right now Paul Ryan, as well as the President of the Senate, right now Vice President Pence. And it is a 17-member body with diverse expertise in the financing and delivery of healthcare services. And in their March report, they release 2 reports a year, one in March and one in June scheduled, and then special reports. And in their scheduled March report, their 15th chapter, it was titled Moving Beyond the Merit-Based Incentive Payment System, aka MIPS. And they quickly identified that the MIPS program will not be successful because it is profoundly flawed in its overall design. And they went through and they really highlighted why this is a flawed program. Well, first off, MIPS replicates flaws of prior value-based purchasing programs of Medicare. There is well-documented research and literature that shows that previous programs similar to MIPS, the value modifiers, and the PQRS programs were not successful at improving population outcomes or substantially improving the care processes. They also identify that MIPS is burdensome and complex. It was estimated in 2017 that $1.3 billion in total cost was incurred just in the reporting of MIPS data. It is estimated for this year that that's only going to be $700 million, so roughly half, but still over $500 million. And that decrease is really because there's a lot more individuals and clinicians exempt from the MIPS legislation this year. MIPS information is likely to be, is unlikely, to be meaningful. They identify that measures should be patient-oriented, encourage coordination across providers, and over time promote changes in the delivery system. And in their viewpoints, the MIPS program does not meet these criteria. MIPS performance scores will not be easily interpreted or comparable across clinicians. So I'm going to read a quote from the report. CMS will derive composite performance scores for each measure in each category based on the distribution of performance scores only for other clinicians who reported the same measure using the same methods. Continued, in other words, clinicians who achieve the same performance level on the same quality measure can receive different scores based on the method which they choose to report. So if you report through your EHR or you report through a registry, you have identical measured performance, but different scoring results. Your score is based on how others perform within your measurement reporting period. They also identify that MIPS contains many special rules, and a significant share of clinicians are exempt, and there's a lot here. They believe that these exemptions will really affect the overall use of the score, and that there's little connection of value and it's not comparable across clinicians. Other flaws, so the low threshold in the first 2 years of the program result in minimal payment adjustments. I missed one. MIPS scores will be very high for most clinicians, limiting CMS's ability to differentiate performance. The current program is designed in a way that you can maximize your score by over-reporting and then being standardized down to a maximum of 100%, or by taking your highest scores but submitting several scores. Therefore, most clinicians are expected to score relatively high, so that differentiation of performance between clinicians will be very minimal, as very finite differences between the two. There will be low thresholds in the first 2 years of the program, which will result in minimal payment adjustments. It is anticipated that 95% in 2017 and 97% in 2018 will qualify for either neutral or positive payment adjustments due to the fact that everyone will be performing very well. So therefore, very few will begin at negative adjustment, which was supposed to be the motivator to move forward. And then in later years, these small differences in performances will be magnified into large differences in payment adjustments. Like we discussed earlier, the MIPS program will start with a 4% payment adjustment, downward or positive in 2017, but this will grow all the way to 9% payment adjustment. So those who have extremely high reporting will see a major payment adjustment, and those who have somewhat mediocre reporting but still positive will only see a minor adjustment. So what should be done about all these identified flaws about MIPS? Well, MedPAC proposes the creation of a voluntary value program. And again, I want to highlight here the difference of voluntary, going back to Secretary Price's testimony when he's being confirmed in the Senate of having a voluntary type program. And they really want to say, how do we do this? Well, they want measures of clinical quality, patient experience, and value. These practice improvements, as well as these advancing care information measures that are currently in the MIPS program, were not highlighted or firmly discussed within the MedPAC report in the chapter that came out. We're yet to see how those types of programs will be implemented into this type of program. They also want to move the focus away from being at the patient level and moving it up to the population level. So how do we look at an overall population of patients? And lastly, how do we link this to make it similar to advanced alternative payment models? CMS and MedPAC both are still really driving towards these AAPMs. Remember, these are the ones that have that financial risk for providers. So how do we really drive in to these programs? So the rest of my slides here are all direct quotes from the report. I'm going to read those because we have a few who are on the phone to make sure you can hear this information. But I also want you to know what was said, and then I'm going to give you my interpretation of that. But if you disagree with my interpretation, you at least have the basis of where my interpretation came from. So what's the differences here? Well, first, clinicians would be eligible to receive a payment adjustment at a voluntary group level. A VVP, voluntary value program, would require only minimal administrative structures. Clinicians would just elect to be measured as voluntary groups, will entail less risk and reward than is required in an advanced alternative payment model for those AAPMs. These voluntary groups would be assessed on a uniform set of population measures that align with the Commission's quality principles. And clinicians would no longer need to report quality data to Medicare because all measures would be calculated by CMS from claims and surveys. So a lot there. So instead of reporting either at your NPI, individual provider level, or having to report amongst your TIN or that tax identification number for your healthcare system, you would have the ability to create your voluntary group, and you would all report. And what that group would mean would be your own choosing and your own look here. The measures would be of population-based measures, and the overall reporting you would have to do would be no more than your claims data and the surveys that you're already doing on behalf of CMS, your HCAHPS and other surveys. There'd be none of this additional reporting that's currently in place with the MIPS program if a program like this were to be implemented. And that's key here. This would take legislation to implement, and no bills have been drafted so far since this report has been released yet. So what would be the spending implications of a voluntary value payment program? So again, direct quote, payment increases would be designed to offset payment decreases in a VBP. In any given year, if the maximum positive payment adjustments were capped and the target set prospectively, a VBP could incur a small cost or small savings, but would be designed to be budget neutral in every year. So there'd be no additional costs to the system in this program. They would standardize that. A VBP would thus produce savings over current law. Under MIPS, an additional $500 million is appropriated each year from 2019 to 2024 for exceptional performance, additional bonuses, or $3 billion over that time frame. However, the Commission's current intent is not to produce budget savings, but to consider policies that would reinvest these funds elsewhere in Medicare clinician payments, so that in total, policies together would be budget neutral. So they would take this money, instead of being a performance bonus, they get reinvested somehow, and they're not clear in their report yet of how that reinvestment would occur back into the system. So either a higher fee for service, an incentive to offer other services, or payment of services that are currently unreimbursable, maybe care coordination or remote patient monitoring, other services that have minimal reimbursement, and get those reimbursable. What would be the provider and patient implications? The recommendations would be unlikely to affect beneficiaries' access to care. It would significantly reduce provider burden to eliminate all quality measures and ACI, so the advancing care information, and CPIA, the clinical practice improvement activities, reporting to the Medicare program. Providers can incur some administrative costs in creating or joining voluntary groups, but the burden would be significantly less than current policies. Designing a process for clinicians to select voluntary groups, CMS could leverage the infrastructures they have been developing for both facility-based measures and virtual groups, which are new pieces of MACRA in 2018 that are being implemented in this reporting year. The recommendations would eliminate extremes in payments by saying lower and upper bounds on adjustments. Overall, VBP would be budget neutral. Some clinicians would see a payment reduction, and others a payment increase. So I think that's really important to highlight here, that this program may still have a voluntary or a payment reduction for some clinicians who are not high performers. There is some risk associated with this model, as well as some bonus potential for participating in this program as well for a payment increase. Excuse me. It's also important to highlight here that they're going to standardize this program all around the advanced alternative payment models. Currently, some providers, and there's been reports in Modern Healthcare and Becker's and other trade publications, that some providers can do better in MIPS than if they were to jump into a risk-based model, which is ultimately where CMS and MedPAC would like everyone to go. So they want to design this program in a way so you cannot get more out of a VBP than you could if you were well-performing within an advanced alternative payment model. So if we want to compare a VBP example to the MIPS program, we got 8 categories to compare with. First, covered clinicians. How's that defined? Well, in MIPS, that's all clinicians except those who are in an AAPM or certain specialties below certain specialties, those who are below a low volume threshold, or those who are in first year in Medicare. In a VBP type model, all clinicians not participating in an AAPM, Advanced Alternative Payment Model, would have the right to choose to participate. Everyone would be allowed to participate. No one would be excluded. The MIPS maximum negative adjustment currently is -9% by 2022. Like we said, this was set in statute. The MedPAC report was produced prior to this Budget Act, or Balanced Budget Act, Bipartisan Balanced Budget Act that was approved. So that may change, but right now, when that report was run, it was -9%. They had set a fixed amount as a prospective withhold. So a few key things here. First off, in a VVP, it'd be a prospective withhold. We would withhold your money starting in that reporting year instead of taking in a post way. And they would set that withhold at around 2% instead of 9%. So a lot reduced away there. The maximum bonus, MedPAC's analysis said the maximum bonus with all of the high performings and the extra $500 million a year, they believe the potential upside reaches 37% by 2022. That's 37% on all Medicare Part B reimbursement. That's a huge bonus. In a VVP, they would want to cap this so that the maximum bonus is smaller than the potential from an advanced alternative payment model. Again, giving you incentive to participate in the program, there'd be a bonus potential, but really want you to jump into that risk-based program. Measures that clinicians need to report. Right now, it's a very complex system in MIPS. You have 6 quality measures. You have to report all of your advanced care information measures. You also have to report clinical practice improvement activities. All of that reporting takes a lot of time, a lot of dedication by a lot of staff. In VVP, there'd be no reporting needed because it'd all be based on claims data and existing patient and provider surveys already being performed by CMS. Clinician elections. So in MIPS, clinicians can elect either hospital-based assessment or virtual group measurements. In a VVP, clinicians can elect to be measured with a voluntary group sufficiently large for performance assessment on all measures. So really, you're not constrained. Well, I'm a hospital-based, so I have to go to my hospital group. I'm in a virtual group. Here's all the constraints of a virtual group. Really, you can do it on whatever level you want, assuming you have sufficiently large performance assessment data. And they're not really clear on what that means and what that looks like. And from a rural perspective, we're very interested in understanding that as well. Level of performance measurements. So MIPS, this is either done at the individual clinician and PI level or at your group, your TIN level, and those are the only 2 levels. Virtual groups are widening that some. VVP is a voluntary group, so it's a little more open. Performance access is based on self-selected quality measures that you attest to your AIC measures and your CPI measures, or the cost approach here. VVP would use a uniform set of measures in 3 categories: outcomes, patient experience, and value, which is measured by cost over value. And patient-centered measures would be similar to those measures already into advanced alternative payment models. So really, again, trying to use this program as a building step into an advanced alternative payment model. And then applications of quality scores would be done, instead of being done at that individual or group at the TIN, be done in a voluntary group, and that same score would be applied across the whole group. So that is in a nutshell what the MedPAC report had. There's a lot here, and for a 1-hour webinar, a lot that we could have gotten into that I'd be more than happy to discuss offline with you, or if there's interest, hosting a more advanced discussion, additional webinar where we can look at some of these points more specifically. But a few summarizing points. First, I want to say that everything we've discussed here about the voluntary value payment program is still all being proposed by MedPAC to Congress to consider for the enacting of legislation that would then be passed through Congress, would it be signed by President Trump, and then be implemented by CMS. None of that has occurred yet. There's been minimal discussions yet at Congress right now about doing that. So please do not be thinking I can stop working on MIPS right now because I have this new program. That is not true. And we'll be keeping you updated as these things advance through Congress and through the federal government. Secondly, it's important to show here that the advanced alternative payment models that was really highlighted in MACRA and that legislation is even more highlighted, more emphasized in this MedPAC report. There's a lot of interest in having a risk downside model for our Medicare reimbursement across the country. And this is one more step leading us into that. And then lastly, it's important to recognize that groups are going to become even more important, either within our system that you currently are employed with or work for, and also outside of the system that you currently work for or are employed by. as you try to figure out these voluntary groups that make the most sense, as you look at your population, where they transition to, where they move to really be able to maximize this patient experience, this outcome, and this overall value. So with that, I'll open the floor up to questions. I will pull up the chat window here to answer any questions that may have. Here's my contact. My email is cmullen@indianarha.org, as well as my desk phone. If you'd like a copy of these slides, please send me an email, and I'd be more than happy to share a PDF version of them with you. If you have further discussion you'd like to have, please let me know. Or would like for me to do this presentation at your facility, please let me know as well. As well as this will be archived on our Lunch and Learn YouTube channel, which I'll let Allie discuss. So with that, I will remain sharing this and open the chat window and open to any questions that may be out there.
Cody, I got a question for you. This is Jim Miller.
Hey, Jim.
With the volunteer program, and based on claims data and surveys, what is the danger of providers possibly upcoding to offset the potential drop in payment adjustments?
I think that's a huge risk that we have right now with MACRA and MIPS because of the cost measure as well. They didn't really discuss that as a potential downfall, and there's a lot of research out there that is a potential downfall. Without knowing more about what type of data they're looking at and how that works, and how voluntary groups are, because being the cynic, I would hate for a patient to leave that virtual group or however that group has been defined, go to another system, and then their coding at that system negatively affects the coding of that other provider. So I think there's still a lot of data there. I think that's also why a lot of Secretary Azar and Administrator Burma is making a lot more data available currently. For example, Part C data, so Medicare Advantage data used to be very highly restricted data for research only. They're now making a public use file that you can download and analyze the data yourself. So I think they're still trying to define how that analysis would work and what they look into.
As a follow-up to that, the surveys that you referred to, is that going to be something similar to what's in place with HCAPS?
Yes, they didn't mention HCAPS, so it reads a lot like HCAPS. So I don't know if it'd be exactly HCAPS or it'd be a iteration of HCAPS, but I think it'd be pretty much identical too.
Okay, thank you.
Thank you.
Thanks, Cody. And of course, if there are any more questions, please do keep them coming in. I do want to point everybody to the chat window where I have shared the survey link, which is just a quick follow-up survey to this presentation to be able to have these free lunch and learns for everyone. We do have to collect certain data for our grantors to see that we're doing what we're saying we're doing, but also that we're bringing you guys good information. So we do appreciate you taking just a minute. It's a very, very quick survey. I think it's 7 questions. Won't take you more than 60 seconds to complete. And also, if you could share what facility you're attending on behalf of, that's another piece of data that we're asked to collect to be able to continue the grant funding for these free lunch and learns. So if you could do that as well, I appreciate it very much. In the meantime, if there are any more questions, we appreciate you submitting those now. Okay, well, not hearing any, I just want to thank everybody for your time today, and especially to Cody Mullen for putting on this great presentation for us. As he mentioned, we will be posting this recording as soon as it is ready to our YouTube channel, which you can find very easily by simply going to YouTube and searching Indiana Rural Health. We also have a link on our website under events where you can click archive the webinars and you can see all of our recorded lunch and learns that we are able to share. So just thank you, everybody. Again, enjoy the rest of your afternoon and just have a great day.
Thank you, everyone, for listening.